So next, we have a session that takes a look at the federal landscape for asthma and respiratory health and how upcoming policy decisions will shape care for patients, caregivers, and providers alike. This discussion will highlight changes in federal funding and policy, including the future of the National Asthma Control Program, potential cuts to safety net programs like Medicaid, and shifts in environmental protections that could impact patient outcomes. Nissa Shaffi is the Director of Advocacy at the Allergy and Asthma Network, and she'll be facilitating this session. As the Director of Advocacy, she serves as the strategic architect of the network's federal and state policy initiatives, leveraging her expertise across federal programs, consumer protections, health systems, and patient advocacy. She'll frame today's discussion on advancing equitable asthma care through policy and advocacy. Joining Nissa are our panelists, some of which are some familiar faces as they presented a little bit earlier today. And we also have one new speaker. In case you missed their sessions, and to introduce our new speaker, we have Elizabeth Elliot, president of the Maryland Association of Health Nurses. We have Dr. Angela Garcia, medical science liaison for Sanofi. And we have Matt Reiter, who is joining us anew, who is the principal of Capital Associates, to give us the policy perspective. Please welcome me. Welcome me. Don't welcome me. I've been here all day. Please join me in welcoming Nissa and our panelists.
Hey, good afternoon, everyone. Can you hear me? Yeah? Okay. So it's lovely to be with all of you today in beautiful Orlando. Now you can hear me. And my name is Nissa Shaffi. I'm the Director of Advocacy at the Allergy and Asthma Network. We've had a wonderful day of programming today, and I wanted to just help round out the discussions with a discussion on where the state of federal affairs are in the healthcare space. And we have a great panel today to help uncover some of those changes. I want to give a fair warning that my keynote is going to be a bummer. There's a lot happening and it's happening fast, but we have some really dedicated advocates in the asthma space that are going to help us navigate those changes. So first and foremost, I want to go over some of the insurance coverage changes that we're going to see and help make sense of what's already happened. Earlier this year, federal Medicaid work requirements were signed into law, which will mandate employment as a condition of health coverage starting in 2027. At the end of this year, pandemic-era premium subsidies, also known as enhanced advanced premium tax credits, are set to expire. These subsidies have made health coverage more affordable for individuals through the health insurance marketplace, or insurance that's purchased through healthcare.gov. And if they're not renewed, starting 2026, premiums across the board are expected to go up by 30%. And more immediately, we have also exceeded a month into the government shutdown. We're on day 38 today, where critical funding for federal programming is at a standstill. Top of mind, of course, is the pause on supplemental Nutrition Assistance Program benefits, or SNAP, which provides food assistance for low-income families. For children in particular, food insecurity can be associated with higher rates of asthma, and hunger leads to increased stress, inflammation, and poorer diets. We heard about this from Dr. Israel earlier today, and there's also a specific study by the Journal of Social Science and Medicine, which highlights that robust SNAP benefits leads to a reduction in ER visits in children specifically. Especially relevant to this convening is the fact that future funding for the National Asthma Control Program, or NACP, hangs in the balance. The US Asthma Summit was started in 2015, so 10 years ago was the initial convening, and it was done so with funding from the NACP and support from the Centers for Disease Control and Prevention, or CDC. Over the past decade, Allergy and Asthma Network has worked with the NACP to highlight successful stories from state asthma control programs, including the implementation of the Exhale program strategies. And Allergy and Asthma Network recently received an extension of a 5-year cooperative agreement this year to continue the program. We received funding for the extension, and then directly after that, the government shut down. So I mentioned that it's going to be a bummer, but there's a lot happening, and we are facing a landscape rife with serious challenges to asthma access and policy. To help us navigate these changes, it's my pleasure to introduce our panel, a powerful group of experts from various perspectives, each uniquely dedicated to advancing patient advocacy. So it's my privilege to welcome to the discussion Matt Reiter, Liz Elliot, and Dr. Angela Garcia. Matt serves as the principal of Capital Associates, a lobbying firm based in Virginia. Liz is a nationally certified school nurse board member. You've heard from her earlier today. And Dr. Garcia serves as a consultant pharmacist at AS Garcia Consulting, sorry. The first half of our discussion will focus on insights from the panel to fill in some much needed context on the work ahead in navigating these challenges. The latter half will focus on actionable steps we all can take to ensure that our communities are living healthier, more empowered lives. So starting off, I wanted to go over, I mentioned many of the themes regarding health insurance, and they all signal a loss of coverage, mainly from the Medicaid space, where we're expecting over the course of 10 years, 15 million people will lose coverage due to work requirements. The individual market with the expiration of the premium subsidies, and consumers potentially foregoing coverage altogether because of the rise of premium costs. Liz, I wanted to start with you. When we prepared for this panel, you mentioned that there was a tsunami heading our way with fewer kids with medical assistance. And earlier, we also learned about the nexus that nurses play at the center of care in terms of case management, data reporting. I wanted to see, how do you think these changes will affect school health services in particular, especially students with asthma?
So that's a great question, Nissa. Can you hear me? Am I on mic? Fantastic. So again, we're going to have some changes, and exactly how they will unfold is to be seen. But I think it will be a combination of fewer children covered by medical assistance. In the state that I live, it's estimated in Maryland, and again, this is a broad estimate, 1 in 4 students is covered by medical assistance. So we think that will go down some, which means that there's more students without insurance, and the school nurse has to, stretch just a little bit more and get more creative about the medical safety net for those kids. But then perhaps there might be more students who actually do sign up for medical assistance, because I think that the economy might not be growing at quite as robust of a rate. In Maryland and the DC area where I live, far fewer families and far fewer people are working for the federal government, and those families are really astute and know how to apply for public benefit. So we think there may be, some more kids potentially shifting from private insurance to public assistance. But again, I'm not sure. We just know changes are coming, and the pressures on school health and school nurses are going to increase.
Thank you. And Dr. Garcia, as we prepare for this diminished access to coverage, what do you see in terms of how patients are going to navigate the pharmacy counter and how pharmacists can help them do that?
So it's always important. One of the opportunities that I had was working in a pulmonologist's office, and my job was if the family was having some sort of issue at the pharmacy, like what was the point of the problem? Because anything that stops at the pharmacy then stops with continuity of care. And so it's important that pharmacists get to a place where they understand their role in advocacy, but that the health system recognizes the importance of the role of the community pharmacist. Because once they leave the health system, the last person who should be the stopgap is that community pharmacist. And without the support for the community pharmacy and the community pharmacist's role in educating patients, if they're understaffed because of financial gains for the company, that's not part of the health system, right? The health system is to figure out a way to provide the services needed. It will be important for pharmacy staff, the pharmacists, the technicians, the interns that are there, to be able to engage with patients and consistently discuss with patients technique and refills. One of the signals that we pick up for a lack of control or loss of control is that the patients stop refilling controller medications and increase the frequency of refilling rescue medications. One rescue inhaler, if used the way it's intended, should last 2 years. 2 years. The number of inhalations per rescue inhaler, if used in a controlled patient, should last 2 years. We fill those every single month. That's a signal of a loss of control, a patient who is not well controlled, and a patient who is missing information, health literacy. And so to understand when a patient is refilling this every month, that this is an opportunity to make an intervention now, because this is the patient who ends up in the urgent care, in the emergency department, in the hospital, or passing away. That's the reality. And so by being more judicious, being more engaged, being more verbal, and really serving as an advocate for the patient, the pharmacist and the pharmacy technicians and interns have an opportunity to start that engagement. There are prescription plan savings programs. Has anyone tried to use one of those? They're like 50 pages long. They take hours. You have to send it over to someone to sign and then another person to. It is not, it's intended to be a great opportunity to help with prescription costs, but the hoops you have to jump through to even get that program to benefit the patient, it's unrealistic. There has to be a change in that system. The way that pharmacy benefits managers were intended to work is to say, we think that there's a better way to organize the medication to improve the outcome. But for them to stopgap every time a physician writes a prescription, every time a therapy is needed, the person who makes that decision, your physician, your specialist, they know what's in the best interest of the patient. And when they can't treat the patient the way they need to treat the patient, the way they want to treat the patient, that's a signal there's a problem with the system. And so whether it's finding opportunities for access, opening the interest and the safety of participating in studies, because patients can get medication for free when they're involved in these studies, learning that, you know, preventive care, what stages that a patient has. I love the question that the gentleman asked about what if we put him on a biologic first and start to get, those are really expensive medications, but if we can get a patient controlled, we can reduce the costs of emergency care, of frequently missed schools, school days, work days, all of those things. But it's frustrating and it's hard. I can tell you, I worked for a chain pharmacy for 10 years. And the worst part of my day was when a person would tell me, I can't afford this. And there's something in you that just dies right then and there because you want to buy it for them, but you can't afford it either. And it shouldn't be that way. It shouldn't be a situation where a person has to say, I can't actually afford to pay for this, even though I know it's going to save my life. That's not okay. And the system has to change. And the way that changes is advocacy, and it takes every person's voice.
Thank you so much for that. So I'm hearing common themes here that even though these changes are going to be happening at the federal level, we're going to feel the brunt of it locally, both in terms of our school infrastructures and then how our healthcare providers, pharmacists included, are going to be navigating those changes. So Matt, as a government affairs professional, you hold a premium vantage point in this situation. And I wanted to ask you if you could provide some context into what's happening, what are some of the legislative negotiations going on, if you could just provide some color to that.
Of course, and just to briefly and further introduce myself, since I'm the new face on the panel. Again, I'm Matt Reiter. I am a lobbyist for the college. So I'm here because I represent the college on legislative advocacy topics. I've been doing that since 2014. But that work has some added personal meaning to me because I'm also a patient. I'm on allergy shots. I'm on a biologic for asthma and nasal polyps too. So loved hearing Dr. Blaze's presentation, love hearing the information about being under control, not using a rescue inhaler for 2 years. I'm glad to know I meet that definition right now, but wasn't necessarily always that way, right? So, but this work and this group in particular has a lot of, added personal meaning to me. I mean, we do with the Allergists a day of advocacy, in conjunction with Allergy Asthma Network too. So I'm happy to be kind of partners with the Allergy Asthma Network so much in that. But yeah, just to add some color to the conversation we've been having just here, looking at starting with kind of the ACA, right? And that's why the government's shut down right now. What's the issue really is that during COVID, Congress decided to expand eligibility to the ACA premium assistance. So for those not familiar, typically with insurance, at least pre-ACA, it was provided to you mostly through your employer, and your employer subsidized the cost of. What happens if you're an Uber driver or an independent contractor? You don't have an employer to subsidize that. So the government said, we'll step in if there's someone who doesn't have an employer to subsidize their insurance, and you can buy insurance through these government marketplaces, and the government will subsidize premiums. However, we're going to cap eligibility for that assistance for people who make up to 400% of the federal poverty level. So think about, I don't know what the federal poverty level is. It's usually around like $11,000, $12,000 or so. So, that's what, $48,000 or so. So if you're making, let's say, $60,000, $70,000, you don't qualify for the ACA subsidies, but you could definitely benefit from it. And to have to pay for the full cost of a health insurance premium at that salary, it's not easy. So by removing that income eligibility limit, essentially anyone was eligible for premiums. And the new formula was just the premiums were based on a percentage of your income. It couldn't exceed a percentage of your income. So that's what's expiring next year for January. And so it would go back to that 400% poverty level limit. So when it came time to fund the government by September 30th, even though Republicans control both chambers of Congress, it takes 60 votes in the Senate to pass a government funding bill. You need at least 7 Democrats, really 8 functionally, because that unless we extend the ACA subsidies. So, and like Nissa said, there could be millions of people who lose access to insurance. I mean, they can purchase the plans, they just won't have the subsidies. And if you look at the data, if you look at the enrollment data, since COVID, since the COVID pandemic, when the enhanced eligibility took effect, the amount of people enrolled in the ACA has doubled. So it was a significant expansion. Now, on one hand, it's very expensive to do that. So those who are, fiscally conservative, right, on Capitol Hill or whoever, to them, they look at it from a not necessarily a patient access standpoint, but that this isn't expensive, right? So you can understand put yourself in the shoes of those people, why they would not want to be the government spending so much money, right? It's really a value statement of, how should taxpayer money be spent, right? And we can debate that, but we know what the result will be in this case, that a lot more people won't have insurance. So from the clinician standpoint, that's one challenge they're going to face, more uninsured patients. Switching quickly to Medicaid before getting to the cost issue, like was described before by Nissa and others, the One Big Beautiful Bill Act is going to lower. There's a lot of things it does, like the work requirements is one thing, but the end result is lower revenues to states from the federal government for their Medicaid programs, and fewer people on Medicaid because of work requirements, more regular eligibility checks. So states are going to have to start verifying eligibility every 6 months, right? So how are health plans going to respond? Are they going to have tighter networks of providers? Are they going to have to pay doctors less? Are patients going to be just left confused about their benefits? There's a whole lot of confusion, a whole lot of financial challenges. Combined, we're seeing 10 to like Nissa said, up to 15 million people losing insurance, right? Over time, it's going to be really challenging. And so, one of the other criticisms that we hear about, about the ACA plans and just health insurance in general and healthcare in general is how expensive it is. Yeah, insurance is expensive, right? Everything's expensive in healthcare. Okay. There's essentially these days other than like Band-Aids that isn't expensive, right? And so I guess Band-Aids maybe they're tariffs now or something, right? But you know what I'm saying. So if you look at drug prices, for example, okay, and what the Trump administration is doing on drug prices. So we already have the Inflation Reduction Act, which allows the government to negotiate with manufacturers for a preset number of products, and is a bureaucratic process. The Trump administration is pushing that while they're keeping it in place. We weren't sure if they would. They're also just going straight to the manufacturers and just negotiating prices with them directly. So, it's basically just, the government negotiating with manufacturers on prices. You have a new model that was just announced yesterday for what's called most favored nation drug pricing, which ties the price of drugs that the U.S. pays to what other countries pay, which is usually lower. Now that would be voluntary and just for Medicaid. We're seeing this new Trump RX website where essentially people can buy prescription drugs directly through this website instead of through their health insurance or PBM. And look, it might be cheaper than using your health insurance price. Or if you don't have insurance, it's cheaper through this website than it would be, in other ways. So, the administration is doing what it can to try to lower the cost, at least of drugs, and they're doing it their own way, right? I'm not going to try to get into arguments one way or another about it, but just trying to kind of explain some of the things that are going on. So, we're looking at, just like Nissa said, just to summarize, challenges in terms of health insurance coverage with more people potentially losing insurance. But at the same time, efforts to try to lower the cost of both insurance and drug prices as a whole.
Thank you so much, Matt. So I just want to run back some of the stats. So I mentioned 15 million coverage loss in Medicaid. With EPTCs or the premium subsidies expiring, we're anticipating 4 to 5 million coverage loss in the ACA. And then the 30% premium increase for everyone across the board. So we're even feeling it now. So it's going to happen. It's going to affect everyone because of insurance risk pools and just how we assess risk within our population. Encapsulating all of that, I'm going to come back to you again, Matt. And I wanted to ask you, it seems that now is more critical time than ever for advocacy. Angela mentioned that as well, Dr. Garcia, sorry. And I wanted to see, what is the biggest window of opportunity for us to essentially strike while the iron's hot? There's a government shutdown. There's not much momentum at this moment, but are there other ways people can get involved to make sure that they can hit the ground running when things open up?
Of course. Yeah. I'd like to tell people that Congress cannot walk and chew gum at the same time. They focus on one issue at a time for the most part. Okay. I mean, it's true. And look, I should also mention that there is an allergist in Congress right now, Congressman Bob Onder, who's actually attending the meeting. He's here today and tomorrow. And so we're really excited to have him. He's been really helpful on these allergy issues. But again, this is what's front of mind right now. Okay. The health insurance issue. Obviously, there's other parts related to the government shutdown. Obviously, everyone's worried about their flights home and then travel for the upcoming holidays, right? We know about that, okay? But I mean, the health insurance issue has been central to this from the beginning, right? And and it's not just health insurance coverage, but it's health insurance costs. It's drug costs. It's front of mind. Now is the time to. The iron is hot, okay? To kind of play off that phrase. So this is the time where advocacy can kind of cut through the other issues. I mean, when you go up to the Capitol Hill in May for World Asthma Day, what's the big topic of the day? What's consuming all the oxygen on Capitol Hill? It could be this, that, or the other thing. But right now, it's our issues, right? So, I mean, who here is kind of active in advocacy in some way, shape, or form? How many of you in the last year or two have written a letter or an email to your congressman or call to left an opinion on something? Okay. How about state legislators too? Because state's important also. Okay, I encourage you to do it. I mean, reach out. I mean, you all have more sway than I do because you're their voters, you're their constituents. When I go and talk to people, I mean, I live in Virginia. I lived in Washington, D.C. for 15 years. I couldn't even advocate my congresswoman because she didn't have a vote on the House floor, and I didn't have a senator, right? So, your voices actually carry weight here. So now is the time to use all the training, all the resources that are available from this organization, from others, to reach out and let them know. I mean, they're looking to hear and put the partisanship aside for a minute. People on both sides of the aisle understand, and there's really is bipartisan interest in the issues. Maybe they might disagree on the exact solution, but everyone agrees that health insurance costs are too high and we need to do something about it. So now's the time to be in their ear. Is that anything else I'm gonna is that's good for now?
That's
I don't want to
perfect.
take up all the time, but yeah.
I also want to highlight that during our prep session, Dr. Garcia also mentioned that, just kind of dovetailing off what you said, Matt, that there's a system of accountability that politicians have to adhere to. So we determine their re-elections, their actual elections. So you are the voices behind a lot of the movement there. And I see you smiling, and I feel like there's a story there about the advocacy that you've engaged in. So really proud of everyone that's raised their hands so far. I want to go back to Liz and talk about the school nurses who can advocate. You've mentioned a lot of the roles that school nurses play on a systemic level, and how would you encourage them to get involved?
That's a great question. So advocacy can take on many forms. You can advocate in your individual school level with the administrators, with the PTAs, with the families for things that are important to your child impacted by asthma and to the community. You can advocate at your district level with the Board of Education, with the county council, with the mayor, whoever is the decision maker in terms of putting school nurses in schools. Currently, 65% of public schools in this country have a full-time nurse, and everyone else doesn't. There's wide disparities regionally in terms of where school nurses are. So school nurses can advocate. Wonderful tools on the National Association of School Nurses website. You can advocate at the state level. I know I have testified in Annapolis, the state capital of Maryland, on numerous occasions on issues of interest to school nurses. And I think getting involved with your professional association is imperative because our voices together are much more impactful than our voices alone. Join the state nursing association, join the state school nursing association. And then at the national level, the network has wonderful resources. Thank you, Nissa. Yeah, had to put a plug in there. And there's some important pieces of legislation at the federal level that have to do with increased funding for school nurses that we'll talk about after Congress has figured out their first major task right now. So I think to be involved, to write the letter, to make the phone call, to show up at your local community town hall days and meet the legislature and get to know them so they call you if they have a school nurse question.
I just want to add one important thing to that too, because it's so important what you said. But to add is you don't have to do it alone. You don't. I mean, in advocacy, it's not just you talking to your elected officials or whoever, it's you talking to your own community. How many of you are parents of a child with asthma or allergy, or you have it yourself, right? How many of you know other parents in your community or other family members that have the same issues, right? Could you form a group, a network of people in your community, whether it's an email chain, a Facebook page for, X town, parents of asthmatics or allergy, whatever, and how do you form those networks so that when it's not just you writing the letter, but you say to all of them, hey, here's a letter we should all send. We should all sign it. Right. And that way you have that network and you have more voices at the table. I mean, you walk around the colleges meeting, we have posters with a QR code for our advocacy letter that we want our physicians to send to Congress about Medicare reimbursements. You're all welcome to sign it if you want, but it's a Medicare reimbursement issue for doctors. It's not quite as, the same types of things we're talking about, but like, don't go it alone. Build your own communities too, whether it's you taking the lead or finding other people to partner with. That's just want to help. Sometimes that helps people feel like they can do more. It's not just writing one letter, it's building a community.
Thank you so much. So earlier today, Dr. Garcia, you mentioned the importance of health literacy and asthma management. I kind of want to pivot. We didn't discuss this question, so I apologize. But I feel like there's an app for everything these days. There's an app to manage your apps. And when you talk about health literacy and managing your conditions, you want to make it as simple as possible for patients, but also how do you factor in tech savviness into that?
So I think that the most important thing you can do, right, the most expensive thing that we have in any component of healthcare is time. Right? It is time costs money. But when you think about the return on investment, if you make time on the front end, it will give dividends that you can't imagine on the back end. And sitting down and having someone walk through what are certain technology opportunities for patients to use to track for themselves, to carry in and take to their provider, or some of the apps will download data and send it over to the provider themselves. But it's important to understand that we make an assumption that people understand what they're doing with their technology and that they understand how to access the technology. And I mean, I look at my dad and we call him chicken pecking because he pops his finger on the phone. So I'm like, you're gonna break the screen. But, and he gets frustrated and he gets overwhelmed and then he's done. And that's it. If we make portals of information and portals for management and portals for advocacy and all of these things in technology, but the technology is not either easy to navigate and not easy for someone who uses technology, but easy for someone who doesn't understand at all what they're doing, because we try to engage them in technology, but that doesn't mean that they're ready for that engagement or that it makes sense to them, right? And that's a health literacy issue. Is we think it makes sense, but for the user, the end user, the person who we're trying to get the information from, it doesn't always line up. We have an amazing technology people that will create technology for medical use. Hardly any of those people are healthcare professionals or community health workers or nurses or social workers or someone who has to be in that navigation. And so it makes sense to them because they are creating it to gather data, but it does not interface with us the way that it should in a common logical sense. And the other issue with health literacy is it's not an education issue, right? And we have people with PhDs that would come into clinic and I'm like, where does this come from? Like, I'm just amazed for the wrong reason that this is your logic, right? Altitudes, you have to be careful with. Altitude does not mean your child can't be on the top bunk at camp. It means like Colorado versus Florida. But, and right. And so the inclination is to be like, what? PhD, had a PhD, and that was the way they thought. And then you have a patient who physically cannot read, but they can associate letters with shapes, and they identify that shape with this drug at this time every single day, and they don't skip a beat. And so when we look at the gamut of health literacy, we have to make sure that what it is that we're trying to gather with data to use to drive initiatives, to drive, advocacy, it makes sense to the person who has to use it, but that it's valuable to them, because then if there's nothing that it's doing for them, they're not going to continue to use it.
That's fascinating. Thank you so much for sharing that. So in closing, I just wanted to wrap up our discussion and then hopefully, if we have time, answer some questions for our panel. So there's a lot that I'm taking away from the conversation, and that what really stood out to me is the importance of advocating at all levels of government, forming partnerships with the infrastructure you have around you. So state associations, providers, community health workers, and the critical role that everyone plays in providing direct patient support. And I just wanted to thank the panel today for their really insightful input. And thank you for the audience for your engagement. So do we have any questions for the panel? Yes. Oh. All for him.
You stand me. Take it.
Thank you so much for sharing all that you have. It's actually a pretty emotional topic, right, with everything that's going on. And so I'm just curious and just want your kind of gut opinion on this. We talked a little bit about the impact that it will have on families, meaning the reduction of insurance and things of that nature. But what we also know, right, is that Medicaid and other things fund positions at hospitals, clinics, et cetera. So I'm very curious to hear what your take on the level of service to folks is going to look like as a result of some of these federal changes.
That is an absolutely amazing question. And you're right. I think that that's the second tsunami. The first thing that will happen as a direct result of decreased Medicaid funding is fewer people with medical assistance. And then we will also see the impact in hospitals, right? State and local health departments, because a lot of those positions are funded through the federal government. And it's not just medical assistance. If you look at some of the other programs that have been eliminated at the federal level, there's a trickle-down effect. And we don't exactly know what it's going to look like yet, but we do see that. Another thing that might happen is a decrease in funding for the Federal Vaccine for Children, or VFC program, that provides vaccines free of charge to the states for students with medical assistance or who are uninsured. But that might be impacted too. There's all kinds of things, and we just don't know. But you're right. That's going to affect the people working in the departments to help administer these programs. Yes.
One other thing I want to say that's related to that, and this is a cyclical problem that we have, and I'm sure everybody in the room can relate to it. When we create a program and it's this beautiful program and it works well and we get it into the community, and then funding changes, and then boom, that service is gone. And then a new program, a new source of funding comes through, and we have a new program, and the community's like, okay, great, this is great. And they get involved in that, and then the funding stops and that program's gone. And then a new program shows up. What we've shown our patients is that they can't count on us.
Yes.
They can't trust us. And so when you break trust, you can't always get it back. And if you can't get the trust back, then where's adherence? Where's the reason to chase health literacy in the first place? So when we cut funding, it's not just the the first two tsunamis that come, right? We're decreasing trust in the community every time we provide and remove and provide and remove and provide and remove. And we wonder why they access the health system the way they do.
Yes.
I mean, it's when one of the things that COVID showed us is that you have fatigue in your providers. And when your providers can't take care of themselves, how can we expect them to take care of patients?
Yes.
And so we are losing a lot of funding that's going to have direct and indirect effects that trickle down into what we come with every day. And those patients show up every day expecting to be important, valued, and helped. And if the money is missing, if the funding is gone, if the stress is so high because you're covering here and you're covering there and you're covering here, then you can't just give them something and think that because they have something, it's valuable or helpful. And I think that's it's fine to contain costs. It's fine to be judicious in your spending. But when you cut back too much, you create more stress, more problems. That leads to more disease. That leads to more disparity. And so it's a cycle that we have to make sure it is a very delicate thing.
That was much more important than what I'm going to say, but because yes to everything that was just said, but I'll be very brief. I saw the 2-minute sign like more than 2 minutes ago, but I just want to add from the policy, angle to it, which again, not as important as the other. It's important, but it is. But part of the One Big Beautiful Bill Act, there was, because they know that hospitals are going to get they're going to get hit by Medicaid cuts for sure. Okay. Now there's part of it is just the way the financing that I won't get into it, but they created this $50 billion called the Rural like Health Transformation Fund, which was essentially, we're going to help defray the costs of the hospitals. Right now, it's 50 billion over 5 years, so it's 10 billion a year for 5 years. Every state applies, and they to the government, but the government will then award it under this kind of policy formula. But then the states have a lot of discretion over how they use that money. So I think it'll be quite interesting to see if states use the funding that they get for that purpose, to address that issue or other issues that we've spoken about.
Thank you. Thank you to our awesome panelists, and thank you to Nissa for moderating such a great discussion. Yes, give them another round of applause. That was just the cherry on the top of our wonderful day here today. I hope you're still with us virtually. Just to take another minute. I promise we will wrap up soon, but I just want us to take a minute and just digest and reflect on what we've learned today and what we've experienced today. I don't know about you, but I've like pages of notes and quotes and yes, and I need to do all of that because there was just so much, right? Biologics, biologic embedding, endotype, evidence base, Gina, right? We learned a lot about smart therapy. We learned so much today, but now what are we going to do with it? Right? What's our next step? We had amazing speakers and sponsors today, but it's really up to us to take what we've learned and do something with it. Some of the themes that I heard today was advocacy at all levels. So we just ended with an amazing panel talking about federal advocacy, but we heard throughout the day about advocacy personally, right? Defining ourselves or defining those in our lives as not asthmatics, as if that's their whole face is just an asthmatic lung. It's someone living with it, and their life is full and defined by way more than just this chronic disease, and we should treat them. Advocacy with our clinicians, right? Are we bringing questions to them? Are we, as the other healthcare professionals that are part of the patient and family's ecosystem, are we all talking to one another? Are we bringing those questions bidirectionally from the clinicians to the community health workers and social workers and to the families? It's really a circle, right? Not a linear line. Also, education is useless if we're not sharing it, and sharing it in a way that makes sense to the audience. I really appreciated hearing from speakers saying literacy is the key. We want more empowered patients. We do, and that's really important. So we need to take what we've learned today. Gina is a wonderful framework that we all need to make sure we're paying attention to as it's ever evolving. But I also want to challenge you. How are you going to operationalize that when you go home to your patients? They need to know about it as well, but in a way that makes sense. And it's really our duty, right? It's our literacy challenge to make sure that we're speaking in their language. When I say speaking in their language, I mean, it could be speaking in other languages other than English, but it also could be not using medical jargon, not using policy jargon, so that it actually lands. That's something that we need to focus on. The bridge that we've talked about today, our theme is bridging access, education, and innovation. It's trust. Dr. Garcia, I was like, oh man, I just needed to just bottle what you said. It really is trust, again, bidirectionally. If you don't have trust with your provider, are you telling them that I smoked a joint last night and maybe that's why my asthma is like that? But it's on the onus on the providers, right? To also make that a safe space in which to do this, correct? Right? Trust is very important. We need to meet people with no judgment. Honest conversations without judgment, keeping it simple, keeping it straightforward, meeting people where we are. Also important that there are many players in our communities, and they're all of value. People not being recognized for their value also can break trust. School nurses see your child living with asthma more than their allergist might, right? We need to value that relationship. We need to value them with recognition. We need to value them economically. We need to value them with support in all of the ways. We heard today there are various definitions for many of the topics that we've talked about today, right? What is education? What is access? What is remission? One thing I also heard today is that we should not define our work, and most importantly, those who we serve, by their limitations. That's one definition I think we can all agree with. We talked a lot about the costs of uncontrolled asthma in terms of hospitalizations or medication. And of course, the ultimate cost, where we are losing 9 precious lives a day, like Allison. That's really the reason that we're all here. So I just want to leave you. I mean, I could go on and on with all of the nuggets that we learned today, and I hope you all will continue to share that in your communities and in your families. Take the resources that you see there on the back. Make sure that you visit the Allergy Asthma Network website. Please tell folks about the free virtual asthma coaching program for adults, because as we heard here, we heard a great deal of supports, studies for peds, for kids. What about for our adults? We need them healthy as well. Last thing I just want to leave you all with is the future is not someplace where we're going to, but one that we are creating. The paths to it are not found, but made. And the activity of making them changes both the maker and the destination. So I want you to just take a moment, think about what you heard today, what really hit for you, what really hit home for you. What barriers are you going to break when you go home? What new partnerships are you going to form? What challenging conversations are you going to have? Take 1 minute, no poll, just take 1 minute, turn to your neighbor, drop it in the chat, and just, have your accountability partner. What's that one right next step that you're going to take when you leave here today? Well, I'll leave you to it. I won't make you report it out, but I thank you for your time. I thank you for your participation. Please be sure to fill out the evaluation, because we want to be sure that every time we bring this summit, that we're bringing high value, bringing you what you need. So we appreciate the feedback. Thank you for allowing me to be your tour guide on today's journey, and I'll turn it over to Linda to close us out.
Thank you, everyone. I'll try to make this quick. Just a few comments before I close this out. One regarding advocacy. I want to thank Nissa for her wonderful moderating today. And we have a digital we have a digital platform that Nissa manages and leads, and so we'll be in touch with you to get involved in advocacy efforts. One of them that we're doing right now is, we should have a school nurse in every school, and we're going to keep championing that until we get it. So I just wanted to let you know. Also, regarding our Trusted Messengers program, I really can't talk enough about it because it's free, and we want to get you more familiar with it. If you know anybody that could benefit from it, we welcome you to refer them. But the important thing is all these things happening on the policy landscape and worrying about loss of coverage and whatnot. Trusted Messengers fills a gap because we're teaching people in a culturally and linguistically appropriate way how to manage their asthma. So, we really do believe that it's saving lives out there. And so if more people can get connected with it, the better, as far as we're concerned. And then just one comment I just had to do regarding, the issue about apps not being friendly that Dr. Garcia brought up. Digital literacy is just so important. And, we believe in patient-centered healthcare, and you get patients involved in the design of apps. And that way you end up with an app that works for them. And so if you're creating things, think about including patients in it, because it's so important to get there faster and having the final product actually be relevant and work well for them. So with that, I'm just going to say thank you, everyone, for remaining here with us today. I hope you enjoyed the program, found it informative. Over the course of this day, we've listened, we've learned. We've had some wonderful speakers here that I can't thank enough for being here. Sharina, you did a wonderful job moderating. I thank you so much for that. And I want to thank the American College of Allergy, Asthma, and Immunology. They're wonderful partners here with us. They give us this meeting space, which helps us make this whole event possible. So as we depart for the day or log off from our screens, let's remember that true work begins after we leave here. I think Sharina was alluding to that. Take what you've learned back to your homes, to your communities, and share it. And, we really want to change the trajectory of asthma outcomes, make them better for all, reduce the number of hospitalizations, adverse outcomes, and deaths. And let's work together to build sustained action. So with that, I'm just going to say, enjoy the conference if you're staying here. Safe travels. Hope you can get home in light of some of the airline uncertainties right now. And until then, we'll stay in touch. And I thank you again for joining us.